When you're ready, you can start, Johnny.
Okay. Good afternoon and welcome to this afternoon session of Deep Dive. It's brought to you by University of KwaZulu-Natal, and we have two speakers who I'll introduce a bit later in this introduction. It's Dr. Maresce Bizaare and Dr. Jasmine Ramiah. I am I am Dr. Charlene Parasnath. I am a clinical hematologist and the head of clinical hematology at Albert Luthuli Hospital for those that do not know me. Mm. So as I said, today's session is brought to you by Blood SA in conjunction with the South African Clinical Hematology Society and SACIT, and UKZN is hosting today's session. I'd like to introduce you to the deep dive management team, Professor Stelferberg, Dr. Nicholas Smith, she's the National Outreach Officer, um, and Michaela Brooks, she's the Administrative Assistant, and Mrs. Taryn Solomon, Administration and Communications Lead. And we'd like to once again thank the Deep Dive team for putting together this every week and for all the behind the scenes arrangements that go along with it. It is a lot of work, and we are deeply appreciative for this. So, housekeeping notes. All our sessions are recorded and can be found on the website bloodsa.org.za under Resources Deep Dive. Please kindly mute yourself during the presentation and feel free to add any questions or comments to the chat box, and we'll respond to them at the end of the presentation. CPD points will be submitted to the HPCSA for each registered South African attendee. Please ensure that you're attending with your own registered Zoom link and not in a group. Please attend for at least an hour in order for you to obtain your points, and ensure that your HPCSA number is entered correctly when you sign up for the session. If you have any queries or would like to request a CPD attendance certificate for another council or country, please email admin@bloodsa.org.za. If you're not already on our mailing list, you can join via the website under Resources, subscribe to Deep Dive, or use this QR code. We do appreciate some feedback for each session. So please complete the anonymous feedback survey at the end of the Zoom meeting. It just takes a minute or two, so please do that. And some upcoming events. So this weekend is the Physicians Conference being held at the Protea Conference Center, Protea Hotel Conference Center in Stellenbosch on the 4th to the 6th of June. The SASMO SACITS conference is being held from the 7th to the 9th of August in Sandton. So the early bird registration is closed, and so is the standard registration. So please do register for the conference, and for those of you who wish to submit abstracts to this as well, please do so. And then in September, we have our hematology oncology symposium. It's called Beyond Boundaries, From Progress to Access. Sorry, this is from the 2nd to the 4th of October at Century City. And we here as well. Please, abstracts will be closing at the end of June, and we really would appreciate all the academic centers and even non-academic centers to actually submit abstracts and posters. Next week, Dr. Theo Garner and Dr. Perry Lubenberg will be presenting. So genomic medicine and the PHC interface in high-risk CLL, translating risk into optimal treatment. So today we will be talking about Warburg syndrome, an interesting case referred that actually presented to Gray's Hospital, where Dr. Bizaare is serving as the head of department in internal medicine and obviously the only clinical hematologist there. And the case was subsequently referred to us. So we thought it would be an interesting case to share with everyone today. So a little bit of introduction. I was telling Maresce that she gives herself very little credit. So for those who do not know Maresce, she's actually has specialized initially in internal medicine, and she's actually the head of internal medicine at Gray's Hospital, where she oversees the internal medicine registrar training program and also the undergraduate teaching. So Maresce is really dedicated and she serves a huge need in an area that's really underserved. So for those of you who don't know, KZN is broken down into sort of three areas, and Maresce handles area 2 on her own. And we are really grateful for what she does. And she really does have a lot on her plate as well as she's a mom to a busy 7-year-old. And Maresce also is very creative and she likes to dance in her church production. So we know Maresce for that. And so I'd love to introduce you to her today, and she will be sharing the case. And then we have Dr. Jasmine Ramiah. She is a fellow in our unit, and she started off as a medical officer, so she has a lot of experience in our unit. And her MEd was on the Seismic X series analyzer studies, and she's also undertaken a study in sickle cell anemia in our unit. And we hope once she's done with her exam that she will publish this. She holds an MBCHB, MEd, and fellowship in the College of Pathologists, and she also serves as associate lecturer at UKZN and contributes to public hematology awareness through the Oncology Buddies magazine. So beyond medicine, she is a hybrid athlete and a half marathon runner who represented DKMS at her first Hyrox event this weekend and was advocating for stem cell donor awareness. And she's a mother of 2 boys and a wife to an orthopedic surgeon. So with that, I will hand you over to our 2 very competent and lovely speakers. Thank you.
Thank you, Charlene, for that introduction. So Jasmine and I are sharing this presentation, and there's a bit of going back and forth. And because the bulk of the slides are with Jasmine, she will be sharing and hopefully keeping up with me and my speed. Thank you. Thanks, Jasmine. All right. I finally used the Krebs cycle to save a patient. Okay. Okay, so our index patient is a 36-year-old gentleman. He's a person living with HIV, newly diagnosed and initiated on TLD in September of 2025 with a decent CD4 count of 236. And 2 months after initiating antiretrovirals, he presented to his local hospital with the 1-month history of a rapidly growing neck mass, nasal obstruction, significant weight loss, night sweats, some hearing impairment, and difficulty in breathing. He was admitted to surgery at his regional hospital and then transferred to Gray's Hospital, which is our tertiary hospital, to the ENT department where a biopsy was performed. And 2 weeks later, he was reviewed, where he was found to be quite distressed with imminent airway obstruction. A phone call to the pathologist revealed a preliminary diagnosis of a lymphoma. And often that's all that we have. And he was referred to hematology. With us, he was normotensive, tachycardic, and saturating at 97% on room air with a respiratory rate of 20. He had a lymph node mass in his right cervical region, which was quite large, 20 by 10 centimeters, firm, non-matted, non-tender, smooth, non-mobile, with a smaller left cervical region mass of about 5 by 6 centimeters. There was some stridor, and on examination, he had a splenomegaly and hepatomegaly. Next. All right, these were his initial blood results. He had a leukocytosis with the peripheral smear showing neutrophilia, left shift, and toxic granulation, normal hemoglobin and normal platelets. He had a mixed, on his liver function test, there was a mixed hepatic and cholestatic picture. And if you look at his urea and electrolytes, hyponatremia, mild hyperkalemia, and his calcium, magnesium, and phosphate showed hypercalcemia and a hyperuricemia. So if you go to the next slide, if you just think on the Cairo-Bishop criteria, what did he have? He didn't have hyperphosphatemia. Hyperkalemia was not that significant. He did have hyperuricemia. So that is all that he had on his on the laboratory criteria, and he didn't have any of the clinical criteria. Okay, next slide. So the differential diagnosis based on the telephone call with the pathologist was that this was an aggressive lymphoma, and so we considered Burkitt's, a diffuse large B-cell lymphoma, and any of the other aggressive B-cell lymphomas. So given the imminent airway compromise, we decided on cytoreduction. We did give fluid prehydrating with IV fluids, allopurinol, and then he was given cyclophosphamide and dexamethasone. And bearing in mind that he had hyperuricemia, we were aware that we should be monitoring for tumor lysis syndrome, and he was booked for the rest of his workup. This was probably on like a Thursday. On the Friday, the next day after starting the cytoreduction, he was found to be still normotensive, tachycardic, still saturating normally in room air, but he's now hypoglycemic. He was distressed with stridor, and he was also very confused. After correcting for the hypoglycemia, a blood gas and labs were taken. And if you look at his blood gas, I'm not too sure if you can see it there, but his lactate was 15, more than 15, and the glucose had corrected to 5.5. So he had severe lactic acidosis. If you look at his urea and creatinine, he's got now a hyperkalemia. Urea and creatinine have urea at least has increased, but the creatinine has remained the same. And if you look at his CMP, his calcium is 2.61. Phosphate is now elevated at 2.43. Uric acid is usually gate kept. And his LDH was more than 1,200. So if you just go back to that previous slide, Jasmine. So if you look here, what criteria did he meet for tumor lysis syndrome? So he had a hyperkalemia and he had a hyperphosphatemia, and he would have met some of the laboratory criteria for tumor lysis, but nothing for the clinical criteria. And before I tell you how we managed him, we will discuss some of the other outstanding results. So we did eventually get the biopsy results, which was what we had initially suspected. And as you could see, on low power, there was a starry sky pattern. There was numerous apoptotic bodies, and there was diffuse immunopositivity for CD20 and CD10 and BCL6 with a P67 index of approximately 100%. So this was quite suggestive of a high-grade B-cell lymphoma. Further staining was done, which supported a Burkitt's lymphoma. Next. We did do a bone marrow eventually, and this showed there was bone marrow involvement. Next slide. The staging report confirmed that the lymph node mass in the right cervical region extending into the retropharyngeal region, also with the left cervical lymph nodes. All right, with several nodules in the liver. And all right, next slide. CSF flow did show that there was also involvement by the Burkitt's lymphoma. All right, and now I will hand over to Dr. Ramiah.
Thank you, Maresce. Good afternoon, colleagues. So today I'm presenting Starry Sky Sugar High. And we know that Burkitt's is one of the fastest growing tumors. A single cell can double in 24 hours, but to sustain this explosive growth, Burkitt cells require more than just a mutation. They also need fuel. So today we're going to explore just how that metabolism and glycolysis and oxidative stress drives the pathobiology, because perhaps cancer is not just a genetic disease, but also a metabolic one. Okay, so today I'm going to look at Burkitt, the big deal, as well as Warburg effect, and I'm going to discuss principles of management with a focus on the 2025 BJH guidelines. So we know that Burkitt lymphoma is aggressive, mature, high-grade B-cell lymphoma. So what does high-grade actually mean? It means that it's aggressive in its morphology, in its proliferative nature. It's often MYC rearranged and has a high proliferative index, and we measure this by using the Ki67. It's a nuclear stain. It is rare, and according to the literature, it's approximately 4 cases per million persons, but it's slightly higher in the South African setting. It's about 2 to 6 cases per 100,000. And the big deal here, it was described first by Dennis P. Burkitt in 1958. And this was the first malignancy with both a genetic and viral predilection. So he studied 38 children in Uganda with endemic Burkitt's. And these horrific images on the right are actually, they're not real. They're African wood art plaster models. And what they are doing is demonstrating essentially the clinical features of endemic Burkitt. So often they had periorbital and jaw masses. And interestingly, Dennis P. Burkitt also lost his eye, but secondary to a childhood accident. So these images and all his notes were extrapolated from his tumor safaris, which you would refer to as located in the lymphoma belt, and they were topographical and climatic distributions of Plasmodium falciparum. So the graph on the right highlights the proliferative nature of Burkitt's, and it is an enigma or a clinical paradox in that historically it's fatal within weeks, but the near 100% growth fraction also confers exquisite chemosensitivity. So although very highly proliferative, it's also very chemosensitive, and that's slightly an advantage to us who treat Burkitt. In terms of the epidemiological data, it's highest 10 degrees north and south of the equator, so located in areas such as Malawi, Uganda, Cameroon, and has this temporal relationship with Plasmodium falciparum. It's also associated with Epstein-Barr virus, but particularly the endemic form has more than 95% association and slightly less in sporadic and immunodeficient Burkitt's. It's often higher associated with males, and the age distribution, according to the literature, is 0 to 14 years. However, we also have noted in our South African setting, we have a trimodal age distribution, and this is similar to the data in the Western world as well. So in terms of the subtypes, there are three. There's the endemic, the sporadic, and the immunodeficient. So as I mentioned, endemic is associated more than 95% with Epstein-Barr virus and clinically presents with these periorbital and jaw masses, kidneys, adrenals, and the gonads, versus sporadic has a trimodal age distribution, 10 years, 40 years, and in the elderly, 70 years, and clinically often presents with extranodal disease, so involving the CNS, the breasts, the bone marrow. And the endemic form is often associated with Epstein-Barr virus, but also with HIV. Important to note here that the CD4 count is often preserved in those patients with HIV, and it has more of a nodal presentation here. Unfortunately, also can be advanced in nature and can involve the bone marrow and the CNS. In terms of risk factors, it is associated with magnesium and selenium deficiency, with HIV, with Plasmodium falciparum and Epstein-Barr virus, as well as both familial and acquired forms of immunodeficiency. So what about the South African context? So looking at the data from a retrospective review, so this particular study was performed in a single center, tertiary center in South Africa, and was published in 2014. And why the study is so important, it actually evaluated local epidemiological data and the survival data in comparison to the real world and the challenges experienced by South Africa. So we note here that in the South African context, the form of Burkitt that we often encounter is the sporadic form, and clinically these patients present often with abdominal tumors. So this is something we appreciate in our clinical setting as well. And unfortunately, the patients will present with more advanced stage disease, so stage 3 and 4. And this is important because we would tailor our chemo immunotherapy options based on the stage of disease. Unfortunately, the survival outcomes are quite dismal. 5-year survival is about 65%, and the African cohort is associated with more advanced stage disease compared to the Caucasian cohort. Unfortunately, 4 out of every 51 patients relapsed, according to the study, and the stage at presentation was advanced and strongly influenced both the chemoimmunotherapy choice as well as the outcomes of the patients. Some of the side effects appreciated were mucositis, neutropenic sepsis, and gastroenteritis. So how would we make the diagnosis of Burkitt? We would start off with the characteristic morphology. And important to note here that a fine needle aspirate is not sufficient to make the diagnosis of any lymphoma. We would need an excisional biopsy or a true cut biopsy. So here the morphology is very characteristic, and this is very important because it will help to discern between our differential diagnosis, which I will allude to on the slides to follow. So generally what we would see is a diffuse monomorphic infiltrate of medium-sized cells with a round nuclei, finely clumped and dispersed chromatin. But what is so signature about Burkitt's, not only the monomorphic medium-sized cells, but also this deeply basophilic cytoplasm infiltrated with vacuoles that surround the nucleus. They are located in sheets, and what we would see is apoptotic bodies. And what apoptotic bodies essentially are is macrophage activity, nuclear debris, and apoptotic bodies which form cellular fragments. So the stars, or rather the sky, are the sheets of Burkitt cells, and the stars are the apoptotic bodies. We would then perform several immunohistochemical stains that are diagnostic. We would start with a CD45, then moving over to our germinal center markers, CD10, as well as our B cell marker CD20. We would also do a BCL6, a MYC, and a Ki-67. So it's very important to note that the Ki-67 is also very helpful in discerning Burkitt versus the other differential diagnosis. So it demonstrates often a high proliferative index, and it stains proliferating nuclei. We measure it as a percentage of positivity compared to the background. So Burkitt is often close to 100%. So they suggest it's over 95%. We would also do an EBA stain or EBA-ish. We do not stain for the latent membrane protein 1, so we stain for EBA and EBNA 1. We would do a BCL2 and a MUM1, which are often negative. However, BCL2 can be positive in Burkitt's in up to 20% of cases, as well as MUM1, variable between 10 to 40% of cases. It can be positive. The caveats to the morphology is that in immunodeficient Burkitt, we often can appreciate a plasmacytoid differentiation to the cells. So how would we make a diagnosis on molecular basis? The pathogenic fusion is MYC with either immunoglobulin heavy chain or light chain. The heavy chain is about 80% positivity, so that's the signature translocation between chromosome 8 and 14. However, the variants can be the light chain variants. So kappa would be translocation 2-8 and lambda translocation 8-22. So when any translocation occurs with MYC, it is often associated with dysregulated proliferation and loss of apoptosis and tumor progression. But important to note that MYC is not exclusive to Burkitt. It can also be found in some hematological and non-hematological malignancies. So the heme tumors that we would see MYC translocated with is high-grade B-cell lymphoma, plasmablastic lymphoma, multiple myeloma, primary effusional lymphoma. And then some non-hematological malignancies that might express MYC include breast malignancies, colorectal, prostate, neuroblastoma. So we would use a FISH break-apart probe, which has a sensitivity of about 90%, and simple MYC translocations often confer a good prognosis compared to the complex MYC rearrangements. The caveats is that one can also get rare cases of cryptic insertion of MYC. So as I mentioned, when MYC is translocated, we have this constitutive activation and overexpression, augmenting the rapid proliferation and often a centroblastic phenotype. Interestingly to note, and this is also important for targeted therapy as well as for transplant purposes, there are targeted therapies towards TCF-ID3 and BCR, or the PI3K signaling pathway, which is often mutated in Burkitt as well as cyclin D3. And TP53 is mutated in up to 35% of Burkitt. And according to some of the literature I've read, in those specific cases, we would advocate for an allogeneic stem cell transplant, but we're going to touch on that a little bit later as well. So how do we make the diagnosis, especially in our resource constraint setting? I'm going to first reference the NCCN guidelines. And like any hematological diagnosis, you start with investigating, or rather examining the patient. And the NCCN recommendations focus on paying special attention to node-bearing areas, including Walde's ring, and to note the size as well of hepatosplenomegaly. Note the ECOG performance status of the patient, because this often helps with staging as well as prognostication and choosing your chemoimmunotherapy. Note the presence of and absence of B symptoms, and then one would then progress to investigations. You'd start off with an FBC with a differential count, and then markers of proliferation and for tumor lysis syndrome, such as the LDH, and a comprehensive metabolic panel. It's very important to do a uric acid, and just important to note that this particular test gets sent on ice because of the metabolic activity of the cells. Then one would do a PET CT scan, depending on your setting and what is available. A lumbar puncture, it's very important to do both a cytospin and a flow cytometry initially, because once again, this will help to tailor and choose the chemoimmunotherapy of choice. One would do an HIV test as well as a CD4 count and a viral load. A hepatitis B, because we note that when we give rituximab or any of chemoimmunotherapies, it's important to look for hepatitis B for reactivation as well. And then one would do an echo, because part of the chemoimmunotherapy is to give an anthracycline. We would give doxorubicin. So it's important to note the baseline ejection fraction for the patient, as well as all patients should get a pregnancy test in childbearing age. And then interestingly, the NCCN recommendations noted that you could either do a unilateral or bilateral bone marrow biopsy. So we would do a unilateral bone marrow biopsy because often our patients do present with stage 4 disease and have leukemic presentation or bone marrow involvement. So one would have to prove the presence of Burkitt's based on those morphological features that I described, as well as the characteristic immunophenotype. So that is using CD10, 20, often CD5 is negative, as well as BCL2, positive for BCL6 and MYC, as well as a very high proliferative index denoted by the Ki67. FISH is not always needed or required if criteria 1 or 2 are met. However, if not met, it's important to do the FISH for MYC rearrangements, and if negative, it's important to look for 11q aberrations. So just interestingly, the diagnostic criteria for Burkitt lymphoma has essential criteria and desirable criteria. So the essential would be the characteristic morphology, medium-sized cells, monomorphic infiltrate, basophilic cytoplasm, expression of CD20 and 10, absence of BCL2 and a high proliferative index of more than 95%, and strongly expressing MYC in more than 80% of cells, and having that characteristic breakage, so either with immunoglobulin heavy chain or light chain. And then the desirable criteria include a starry sky pattern, because not all Burkitt will have a starry sky, as well as the expression of BCL6 and CD38, and the absence of TDT, because that denotes more of an immature diagnosis, such as a B acute lymphoblastic leukemia lymphoma. And then, of course, the absence of BCL2 and BCL6 translocation. So moving over to a differential diagnosis, when you're faced with a patient with Burkitt, it's always important to combine the morphology, the immunophenotype with the cytogenetic findings. So it's important to consider a high-grade B-cell lymphoma with 11q, because often they will have similar morphology, identical immunophenotype, but will be negative for MYC, and often might express either a gain or a loss of chromosome 11q23. A high-grade B-cell lymphoma, either double hit, triple hit, here the morphology is quite different. They are larger cells, they're blastoid, they also have a high-grade morphology, as well as the immunophenotype might be similar. They express CD10 and BCL6, so the similar germinal center markers, but here BCL2 might be translocated, as well as BCL6 in addition to MYC. And then we have high-grade B-cell lymphoma NOS. Once again, morphology is very different to Burkitt, but, and they also might express a similar germinal center phenotype. They might not express MYC at all, or may. And then we have diffuse large B-cell lymphoma. So here they have a cohesive growth. They are larger cells. They can be centroblastic in morphology, can express CD10. BCL2 is often negative. They do have a high proliferative index, might not be as high as 95%. And MYC, it's important to note MYC is translocated here in up to 6 to 10% of cases. And our last differential diagnosis include B acute lymphoblastic leukemia lymphoma. Here the morphology is very different. We have blasts, large cells with a high nucleocytoplasmic ratio, open chromatin. They're expressing immature markers of TDT, CD34, and they rarely express MYC. So back to our case, this was not just a straightforward Burkitt lymphoma. There were these recurrent refractory episodes of hypoglycemia and lactic acidosis. So Maresce will now then continue with the rest of the story.
All right. So, like Jasmine has said, this was not a straightforward case. And if we compare our patient, the biochemistry, etc., it did not really fit in with the tumor lysis syndrome. So we suspected that it was Warburg. And if you look at the differences, for Warburg, the lactate is quite high, more than 15, which is what our patient had. You could see the pH was quite low versus tumor lysis syndrome, but that's usually due to uric acid and phosphate. Potassium was increased. Our patient had a potassium rather of 6.3, whereas in tumor lysis it is much higher. The phosphate was also increased in our patient. What was unusual, our patient had a high calcium, whereas it's normal or mildly decreased in lactic acidosis versus quite low in tumor lysis syndrome. Uric acid, our patient did have a very high uric acid, and it would have fit more for tumor lysis. At the LDH, our patient had LDH of 1,200, and it is markedly increased in Warburg syndrome. The creatinine in our patient's creatinine was actually normal. And then the glucose, which we noted, was quite low in our patient, and he did require frequent corrections. So next slide. Upon recognition of the Warburg effect, we decided to continue the chemotherapy. We started a dextrose infusion as well as bicarbonate. Thiamine was supplemented at 100 milligrams 8 hourly. We did consult ICU, but this is a state hospital with limited resources and even more limited beds in ICU. We were declined, and so we kept him in our admission ward in a high care setting. It's just more intensive monitoring, and the nurses have an eye on the patient more frequently. All right, next slide. And he made quite a dramatic improvement. By day 3, the patient was lucid. His tachycardia was improving. His airway obstruction had improved. His lactate was improving. You can see his lactate of 8.7, and even his glucose with the continued dextrose infusion was also improving. And you can see his pH is 7.5 with his base excess, was improving. Thank you. So this was his, shortly after all the workup, we'd stabilized the patient, we'd referred him to Nkosi Albert for further therapy, and Jasmine will go into all those details. But at the time of writing this, he had completed 3 cycles of hypercvad, and he was due for cycle 4. And then, unfortunately, we just heard this week that he'd actually demised, and the probable cause was neutropenic sepsis. But Jasmine can go into those details a bit further. Thanks, Jasmine.
Thank you, Maresce. Okay, so what exactly is Warburg effect? It was first described by Otto Warburg over a century ago, and some of us only figured out Warburg this year. Tumor, it's basically a tumor metabolic derangement where glucose is converted into lactic acid. And the purpose is to produce not only an environment full of lactic acid, but also to produce these two side pathways. So the first is, so this is the Krebs cycle where glucose is converted to lactic acid, but it is these 2 pathways that help a rapidly proliferating tumor. The first is the pentose phosphate pathway, which produces as a byproduct nucleic acid synthesis. And the next is the 1-carbon cycle, where serine is converted to glycine. And the point of this is also to produce nucleic acid synthesis, but also lipid synthesis. So the tumor not only produces an environment full of lactic acid, but also produces these 2 substrates in order for proliferation and growth, and that is the lipids and the nucleic acid synthesis for DNA. So why does the tumor want an environment full of lactic acid? It actually is advantageous and has an effect on the tumor microenvironment. It is an early oncogenic effect, and it is what is referred to as oncogenic induced senescence through reactive oxygen species. And the lactic acid modulates both the innate and adaptive immune system with a focus on the tumor-associated macrophages. So what it does is it polarizes these macrophages to a pro-tumor phenotype to increase growth and invasion, as well as to the cancer-associated fibroblasts. It increases them to fuel the tumor by reversing the Warburg effect. So when lactic acid is produced into the environment, the tumor gets converted from an anti-tumor phenotype to a pro-tumor phenotype by decreasing T cells, decreasing cytokine production and proliferation, decreasing dendritic cell proliferation and tolerogenicity, and increasing differentiation and proliferation of T regulatory cells, as well as decreasing NK cell function and decreasing the production of interferon gamma, as well as increasing apoptosis. So whilst it affects both the innate and adaptive immune system, the overall effect is to increase tumor survival and metastatic capacity through this oxidative process driving glycolysis and metabolic acidosis. So what tumors are at risk for the Warburg effect? It is those that are MYC-driven and highly proliferative: Burkitt lymphoma, diffuse large B-cell lymphoma, double-hit lymphomas, acute lymphoblastic leukemias and acute myeloid leukemias, peripheral T-cell lymphomas, as well as some non-hematological malignancies such as small cell lung carcinoma, glioblastomas, hepatocellular carcinoma. The characteristics of the tumor would be those tumors with a high LDH, those that are very proliferative, bulky disease, extranodal disease, bone marrow involvement, HIV-associated lymphomas, and those that are driven by MYC, as well as those tumors with a high Ki67 and those with liver infiltration. So how would we detect Warburg syndrome clinically? It's one patient that has a persistent and refractory hypoglycemia, hyperlactemia, metabolic acidosis, and a high LDH, as well as those patients that present with tachypnea and increased FDG avidity on the PET. And later on, I'm going to be discussing some targeted therapies as well as how do we approach Warburg syndrome in our clinical setting. What are the differential diagnoses as well for lactic acidosis and hypoglycemia? It would be sepsis, shock, cardiac failure, severe anemia, hypoxia, liver failure, and seizures. The use of certain drugs such as metformin, NRTIs, linezolid, propofol, and salicylates, and also thiamine deficiency. So this is why this patient was also supplemented with thiamine. So I'm also going to tabulate the differences between tumor lysis and Warburg syndrome, but note that you can get them concomitantly together. So tumor lysis syndrome is the metabolic complication caused by the rapid lysis of malignant cells, versus Warburg is the metabolic reprogramming of a cancer cell with preferential glycolysis over oxidative phosphorylation, even in the presence of oxygen-rich conditions. Here, the pathophysiology is the release in tumor lysis syndrome of the intracellular contents with metabolic disturbances, and it is as a result of cytotoxic chemotherapy. Versus in the Warburg effect, it's the increased glucose uptake, lactic acid production, which is as a result of altered cellular metabolism, often because of oncogenic signaling, especially MYC and mitochondrial dysfunction. The key metabolic changes in tumor lysis syndrome, as Maresce described, it's the hyperuricemia, hyperkalemia, hypophosphatemia, metabolic acidosis, and the hypocalcemia. Versus in Warburg effect, we have an increased refractory glucose uptake and lactic acid production. The clinical impact of tumor lysis syndrome often, as Maresce describes some clinical criteria: acute kidney injury, arrhythmias, seizures, multi-organ failure. Versus in Warburg effect, we have this resistant to chemotherapy and a rapidly proliferating tumor. So the management in tumor lysis syndrome is the focus of correcting the metabolic abnormalities, but importantly, to prevent this, versus in Warburg effect, to target rather the metabolic pathways through targeting the tumor. So we're going to focus on the treatment of Burkitt lymphoma. And the first aspect is to identify as well as to prevent tumor lysis syndrome. And I'm going to focus on the 2025 BJH guidelines. The first is to assess the disease histology. So those tumors with a high-grade morphology are often at higher risk for the development of tumor lysis syndrome, as well as to assess the disease burden, for example, bulky disease, extranodal disease. And then looking at the patient-related factors, for example, patients with renal dysfunction, renal involvement, frailty, ability to manage prophylactic strategies such as compliance with oral intake, and those patients with pre-existing or spontaneous tumor lysis syndrome or laboratory criteria. And then looking at the therapy of the patient, are they at risk for tumor lysis syndrome based on, for example, venetoclax usage, CAR T-cell therapy? And then how do we make the diagnosis? We would use the Cairo and Bishop criteria, and one needs to have either one clinical and one laboratory, or 2 laboratory criteria within 24 hours. The time frame of tumor lysis syndrome characteristically occurs within 3 days prior or 7 days after the initiation of chemotherapy. And as Maresce did describe some of the biochemical abnormalities, one experiences a uric acid increase of more than 25% from the baseline, or a value of 476 micromoles per liter. We would use 8 milligrams per deciliter. So just bear in mind the unit that the laboratory is using to measure this. The potassium is more than 6 millimoles, phosphate more than 2.1, and the calcium is often low, less than 1.75, or once again, a decrease or from 25% from the baseline. And then the clinical criteria is an increase in creatinine of more than 1.5 times the upper limit, cardiac arrhythmias. So on my investigation of what cardiac arrhythmias are commonly found, the literature did denote that even a sinus bradycardia might be indicative of a tumor lysis syndrome. But one would also be mindful of those associated with hyperkalemia. So that's the absent P waves, tall T waves, broad QRS complexes. One can also experience ventricular tachycardia, atrial fibrillation, and ventricular fibrillation. And then the clinical criteria also includes sudden death, as well as seizures, which are non-specific to tumor lysis syndrome. So tumor lysis syndrome essentially is the rapid breakdown of tumor cells as a result of treatment. And the consequence here is acute renal impairment, cardiac arrhythmias, and seizures. Generally, how we would manage this patient, and I'm going to go into a bit more detail, but we would aggressively hydrate the patient, give prophylactic treatment with allopurinol, rasburicase. Rasburicase is also used for high-risk patients, also for the management of tumor lysis syndrome and the prevention. And then one would consider a pre-phase therapy with steroids and chemotherapy. So in our setting, we would use cyclophosphamide, vincristine, and prednisone. So we would use a COP-based regime. So this one slide highlights the entire BJH guideline into one compact slide. It is very busy, but I'm going to break it up. I'm starting with the left upper quadrant. What are the risk factors for tumor lysis syndrome based on the hematological diseases? So low risk would be a myeloma and a CML. However, it depends on the white cell count as well. As well as a CLL is low risk. However, with the advent of venetoclax, it then pushes the patient to more of a higher risk. In terms of AML and ALL, when the white cell count is over 100 or bulky disease, it is associated with a high risk of tumor lysis. And then in terms of Burkitt, advanced stage disease, so that's stage 3 and 4, bulky disease, high LDH is associated with a higher risk of tumor lysis syndrome. It's important to note the pre-existing renal dysfunction, features of spontaneous tumor lysis, and what treatment the patient is on, of course. So just highlighting once again the metabolic pathway of nucleic acid breakdown, we have excess purine catabolism, hypoxanthine is formed, and with the conversion of xanthine oxidase forms xanthine. And we know that our xanthine oxidase inhibitors are allopurinol and febuxostat. And then from xanthine, uric acid is formed with the assistance of urate oxidase, gets formed into more a soluble form, which is allantoin, is then excreted into the urine. It's important when dealing with the prophylaxis of tumor lysis syndrome to hydrate the patients. Generally, they recommend 2 to 3 liters per day with a urine output of about 100 mils per meter squared per hour. And we would give allopurinol dosed at 300 milligrams once a day, but we would dose reduce to 100 milligrams daily if there's renal dysfunction. And note the skin reactions associated with allopurinol. That's something we've also experienced within our setting. If you have access to febuxostat, it is also a xanthine oxidase inhibitor. It is recommended when one experiences skin reactions or any adversities to allopurinol. One can dose febuxostat at 120 milligrams daily. It's not recommended in children, and just to be mindful of the cardiovascular toxicities associated. But according to a phase 3 double-blinded study, there's no efficacy or in improved tumor lysis prevention compared to allopurinol. Okay, and then rasburicase can also be used. It's recommended for those patients with high-risk disease, and it is dosed, and the literature is quite contentious with reference to this. It is either dosed at 3 milligrams daily, or it is dosed depending on the weight. So if the patient is 30 to 60 kilograms, would get 3 milligrams, 60 to 90 kilograms would get 4.5 milligrams, and those over 90 kilograms would get 6 milligrams daily. So it's generally given for 5 days. And note that when testing uric acid, it must go on ice, as well as rasburicase must also be stored in the fridge. If the patient now we're looking at the block on the right, upper quadrant, if the patient has established tumor lysis syndrome according to Cairo Bishop criteria, one needs to aggressively hydrate the patient with fluid, and we need a target urine of 100 mils per hour. Then the patient needs to have uric acid clearance. With now the rasburicase is dosed depending on the weight at 0.2 milligrams per kg per day, up to 7 days. It's generally given between 3 to 5 days. One would stop allopurinol, as you cannot use rasburicase concomitantly with allopurinol. Okay, and then they also recommend that you shouldn't give low dose or fixed doses of rasburicase if there is established tumor lysis syndrome. Continuing monitoring the tumor lysis blood, so we would do an FBC, we would do the biochemical parameters, looking at the uric acid levels, just important that that goes on ice, the CPM and the potassium, either 6 hourly or 12 hourly. And the kidney replacement thresholds or dialysis thresholds are lower than those for acute kidney injury, especially if one has refractory hyperkalemia or fluid overload or acidosis. And then very interestingly, some of the recommendations by the BJH, they recommended that rasburicase must be available for administration within 1 hour of prescription. Unfortunately, we don't have access to such within the state sector, but I would be very interesting to know the experience of our colleagues in other centers or in the private sector as well. And then just to note that rasburicase must be stored in the fridge. One must also test for G6PD or methemoglobinemia, but do not wait for the results before instituting emergency treatment with rasburicase. And then the BJH also recommended that systemic handovers must be done in order to ensure that tumor lysis prophylaxis and treatment is consistently prescribed when transferring patient. And I think this is an extremely important message, that especially us as clinical hematologists have this obligation to impart our knowledge on tumor lysis syndrome management, especially to the base and peripheral hospitals, in order to save lives and improve treatment outcomes for our patients. So how do we treat Burkitt lymphoma? Well, initially we started with the standard diffuse large B-cell regimes with CHOP, and those failed dismally because what Burkitt needed was dose-dense, dose-intense treatment. So Ian McGrath actually introduced the R-CoDox-M IVAC protocol in 1996, and that improved the overall survival rate for these patients significantly because of the CNS directed and penetrating treatment. And then, of course, when rituximab came on board, it also helped to improve the outcomes significantly. And this was studied by the LMB French trial, studying 260 patients. And when chemoimmunotherapy with rituximab was used, the three-year event-free survival improved, as well as the overall survival. So we would start to stage a patient based on Ann Arbor. Then we would risk stratify a patient to either low risk or high risk. And this is going to help tailor our chemoimmunotherapy. Those with low risk disease have a low LDH. This is according to the NCCN guidelines. Stage 1 disease or a single abdominal mass that's less than 10 centimeters, so it's not bulky or it's completely resectable. High-risk disease is stage 2 to 4, according to NCCN. Stage 1 and abdominal mass or extranodal mass or extra-abdominal mass, that's bulky, more than 10 centimeters in diameter. So we're going to look at the first protocol, which is the McGrath protocol, introduced by Ian McGrath in 1996 and then validated over several studies in UK and Turkey in 2002. And here, this is a brilliant protocol because we have treatment that penetrates into the CNS. It's those high doses of methotrexate, high doses of cytarabine. But the drawback here, and particularly in the study, was that not many patients can tolerate those toxicities. And that's something we also experience in clinical practice, that yes, the overall survival rates are good, but there's extreme toxicities with these protocols. So if one has low-risk disease, they will get 3 cycles of R-CoDox-M. They will not get the IVAC component. However, if they have high-risk disease, we will alternate. We will give them 4 cycles, alternating R-CoDox-M, R-IVAC. And just to note what is in the protocol, it's cyclophosphamide, doxorubicin, Vinc, ifosfamide, etoposide, and Maresce. We would also give these patients CNS prophylaxis with intrathecal methotrexate and cytarabine to treat and to prevent the CNS disease. And it's given, the intrathecals are given day 1, 3, and 5 in CoDox, as well as day 5 in cycle 2 and 4 of IVAC. The next protocol that I'm going to mention is the hypercVAD. So this was adapted by the MD Anderson protocol and initially was used to treat acute lymphoblastic leukemia lymphoma, but is also very efficacious for Burkitt because of the Part B block. It has high-dose methotrexate and cytarabine. So here the 3-year overall survival rate was about 49%. However, they noted that there's extreme treatment-related mortality in those patients that are over 60 years of age. The overall survival dropped dismally to 17%. The Part B block is one we would start first if the patients have established CNS disease. So here, what is the components of hypercVAD? It's cyclophosphamide, vincristine, anthracycline, doxorubicin. There's a steroid base, dexamethasone, and Part B is the CNS cover, methotrexate and cytarabine. We would give a total of 8 cycles, so we would give 4 cycles of Part A and 4 cycles of Part B. The disadvantage with hypercVAD, though, is the prolonged hospitalization. So these patients stay for a prolonged period, and often it's quite frustrating for both the patient and for us as well. And then these chemotherapy regimes are not commonly used. They're commonly used, however, in pediatrics, and that's the CAL-GB or the LMB regime. In the CAL-GB, they started off with a pre-phase of COP, cyclophosphamide, prednisone, and then they would give alternating cycles of ifosfamide, methotrexate, Vinc, cytarabine, etoposide, and dex, with the exclusion of ifosfamide. And they noted here with the advent of rituximab that the overall survival, the 2-year overall survival rate, improved significantly to 74%. Versus in the LMB regime, it was standard to give the patient, to risk stratify them, and those with high-risk disease, they then got a pre-phase debulking. In the low-risk group, they didn't get a pre-phase debulking. They proceeded straight to COPAD, which is cyclophosphamide, doxorubicin, vincristine, and PRED. So here, in both of these regimes, I wanted to highlight that they gave radiotherapy. And radiotherapy, so they gave 12 intrathecals with 24 grays of radiotherapy. So radiotherapy is no longer favored in the treatment of CNS disease in Burkitt. However, it does have a role. It's patient-specific in view of the toxicities, but we would reserve radiotherapy for those with CNS refractory disease, relapse CNS disease, those with refractory leptomeningeal disease, and for those that require palliation. And then the star in Burkitt's is the dose-adjusted R-epoch, and the protocol consists of rituximab, etoposide, prednisone, vincristine, cyclophosphamide, and doxorubicin. The data suggests that there's 100% overall survival rate after a 6-year follow-up, but these were patients that were low-risk disease. The caveats to this, although there's low treatment-related mortality, low febrile neutropenia, this particular protocol is not efficacious if you have established CNS disease. It is more tailored for patients that are older, HIV patients, those patients that are unfit for Codox, MIVAC, or hyper-CVAD. It's not great for those patients with established leptomeningeal disease. So what we would give is our dose-adjusted R-epoch with CNS prophylaxis in the form of intrathecal methotrexate. And how we dose adjust R-epoch is based on the ANC, the platelet count, and the bone marrow recovery. So in those patients that are low risk, we would give 3 cycles, and those patients that are high risk, we would give 6 cycles of dose-adjusted R-epoch. So just comparing all of the regimes, I wanted to highlight here that in dose-adjusted R-epoch, the studies were done in older patients. The average age was 49, and the treatment-related mortalities were 4% compared to R-Codox MIVAC, the McGrath protocol, younger patients, but a higher treatment-related mortality of about 8%. So one always needs to balance when choosing chemotherapies, the ECOG performance status, the CNS disease, the stage of disease, comorbidities, and very important to consider the tolerance of the patient. Moving over to rituximab, we know this from the LMB trial that the 3-year overall survival rate and event-free survival improved significantly with the advent of chemoimmunotherapy. And having a low CD4 count does not preclude the utility of rituximab. One can have a low CD4 count, but just bear in mind that if under 200, one needs to give PJP prophylaxis. So now we know the different chemotherapy regimes. How do we use them? When one has low-risk disease, so that is the ECOG performance status of less than 1, stage 2 or lower, a normal LDH, and just note the definition of bulky disease here is less than 7 centimeters. One would give 2 cycles of dose-adjusted R-epoch and then do a PET scan. Important to note that a PET scan is either done upfront to denote the extent of the disease, and this is an interim PET, or end of treatment response to assess complete metabolic response, and then using the Duval criteria to describe whether one has complete metabolic response or refractory disease. Then if there's still residual disease or PET negativity rather, one would give 1 more cycle of dose-adjusted R-epoch. However, if there's PET positive disease, one would give 4 more cycles with intrathecals of methotrexate. If there's high-risk disease, we give 6 cycles of dose-adjusted R-epoch with intrathecals methotrexate. If we're going to use the modified McGrath in low-risk disease, and that is determined by a tumor size of less than 10 centimeters and a normal LDH, we would give 3 cycles of R-Codox M. We would not give the IVAC component. However, if there's high-risk disease, one would give R-Codox M alternating with R-IVAC for a total of 4 cycles. And note the difference once again in tumor and in the definition of bulky disease. Here they use 10 centimeters. 7 centimeters is slightly stricter, but there's no value, and neither value is biologically absolute in the definition of bulky disease. And then looking at CNS disease and Burkitt, Unfortunately, 30 to 50% of patients will develop CNS disease if they do not receive prophylaxis. So one needs to balance the toxicities of, for example, the McGrath protocol, which has excellent CNS penetrating drugs in the combination of intrathecals, versus giving dose-adjusted R-epox, which has less toxicity and using intrathecals. If one has established CNS disease, however, the NCCN recommends that initiate the component of the chemoimmunotherapy that has the CNS penetrating drugs first. So, for example, if you're going to use R-hyperCVAD, you will start with part B before proceeding to part A. They suggest using Codox M IVAC alternating and intrathecal methotrexate and rituximab, or hyper-CVAD or dose-adjusted R-epoch for 6 cycles with methotrexate. The NCCN also recommended for the first month, one needs to receive twice weekly intrathecals. Then the next 6 weeks, it is weekly intrathecals. And then for the next 6 months, it is monthly intrathecals for those with established CNS disease, and that would be established on flow cytometry. And then looking at the elderly patient with Burkitt leukemia lymphoma, I couldn't find in the literature the definition or the age criteria or cutoff of elderly. So some studies used 40 years, some used 60 years. But overall, when the treatment-related mortality jumped to 17% in those over 60 years of age, and treatment-related mortality was highest, particularly those receiving hyper-CVAD. So in this particular instance, one would rather use a chemotherapy regime that has less toxicity profile, and that would be dose-adjusted R-epoch. So what about the relapse and refractory setting? It depends when the patient relapsed. So if they relapsed under 6 months of CR1 after first line of treatment, unfortunately, it's best supportive care or a clinical trial within your setting. However, if the patient relapsed more than 6 months to 18 months after the first CR, one would consider a clinical trial or proceed to second-line therapy. So in our institute, we would use our ICE, our DHAP, our IVAC, dose-adjusted R-epoch for 6 cycles with intense methotrexate. One could also use GDP and rituximab, glofitamab, or polatuzumab. I'm going to be discussing that as well. And then one would assess for complete response and give a consolidation with an autologous stem cell transplant. The outcomes with an auto are better when they relapse more than 6 months after CR1. And if they go into a complete response before transplant, then the outcomes are better. If they have chemosensitive disease, low disease burden, and of course, if they do not have CNS or bone marrow involvement, then consolidation with the autologous stem cell transplant has better outcomes. There is role for an allogeneic stem cell transplant, and the special cases would be those patients that fail autologous transplant, those that relapse 6 to 12 months, younger, fitter patients, multiple relapses, and the literature also says TP53 mutated disease. However, we would not perform an allogeneic stem cell transplant in the elderly and those with refractory CNS, poor ECOG, and persistent refractory infections. So just looking at some experimental and emerging treatment, what about CAR T-cell therapy? Unfortunately, Burkitt was excluded from the big CAR T-cell trial. So that's the Zuma, the Ascend, and the Juliet trial. But we have evidence of single case studies. The challenges, though, in those particular case studies were the high proliferative rate of Burkitt's, CRS, the CNS disease, and dual antigen escape. So they recommended using a dual CAR with CD19 and CD22 to mitigate that. And then bispecific T-cell engagers such as glofitamab. This was studied in the NEGM by Pricker et al. In 2025, and they looked at 3 patients with relapse refractory disease. All 3 patients after receiving glofitamab had a complete metabolic response. And how they administered glofitamab was with obinutuzumab on day 1. Then they gave Glufit on day 8 at a lower dose, and then on day 15 as in a ramped up effect. And that is what we anticipate. Some of the side effects were ICANS, cytokine release storm, and cytopenias. And then polatuzumab can also be used. So that is our anti-CD79B monoclonal antibody with a drug conjugate. And it was dosed at 1.8 milligrams for every 21 days. It was also used with rituximab and chemotherapy. And here the side effects were peripheral neuropathy, infusion reactions, and cytopenias. So back to the Warburg effect, are there any targeted treatments we can use? And most of these are really experimental. And these include our GLUT1 inhibitors, our LDH inhibitors, epigenetic modifiers, mitochondrial function activators like metformin and HIF1 inhibitors. But practically in the real world state or sense, how would we manage Warburg effect with the patient that we are faced with? The first thing is to provide rapid cytoreduction, but balance against catastrophic tumor lysis syndrome. Recognize type B lactic acidosis and note that the lactic acid will drop 48 to 72 hours of administration of treatment, as wonderfully showed by Maresce in this case. Avoid overfeeding with dextrose. So ideally, we want to maintain a glucose level between 4 to 8. One needs to give thiamine replacement and to give a steady state controlled infusion of glucose. And once again, to get ICU support if necessary. So my final take-home message here, from the starry sky morphology to the sugar high metabolism of Warburg effect, Burkitt lymphoma represents cancer at its most biologically explosive. The very mechanism that fuels its rapid proliferation also drives the catastrophic metabolic complication, and that is tumor lysis syndrome and lactic acidosis. Ultimately, successful treatment depends not only on controlling the tumor, but understanding and interrupting that metabolic engine behind it. So thank you for your attention. These were the references and the wonderful team that I work with at Albert Lutuli. Thank you so much for your time.
Thank you, Jasmine, for that really in-depth and really excellent overview of Burkitt's and the Warburg. So I just want to circle back to Maresce's team at Gray's. Oftentimes, we inherit these patients quite sick at Albert Lutuli, but I just want to commend the internal medicine registrar, because I happen to have been covering Maresce that weekend, and this internal medicine registrar and the consultant who were managing this patient really did a really good job. Because when they called me, I thought, you know what, is this patient having tumor lysis? But we had the discussion, and the reg is telling me, you know what, this is not in keeping. And then he called me back and he says he thinks this is Warburg effect, and the patient was really ill. And the next day when he called me, as Maresce said, they'd been managing him in quite resource constrained circumstances, but the patient made a very good turnaround and they continued to give the chemotherapy. So I just think that, you know, it was an excellent example of what astute clinical medicine and teamwork, and, you know, us speaking to each other about the case, that this patient eventually made it to us in a stable condition. So, you know, unfortunately, the patient did pass away from his severe neutropenic sepsis, but Jasmine touched on a few of the protocols. And I see Cecile says R-EPOCH is infusional and very difficult to give in the state sector due to the complexity. Yes, I agree with you, because unfortunately, in the KZN situation, my experience over the years is that majority of the patients that we see are HIV positive, and we've inherited patients that were ARV naive, and those that have had, they been on ARVs for a while and with good control. So we have a spectrum of patients, And we tend not to use just one protocol. So if you have a patient that's well controlled, we might go with our hyper-CVAD protocol. But if we get a patient that's unstable, we would debulk and then maybe consider the R-EPOC. And if the patient makes it through, then we would give a sort of when the neutrophil count recovers, we would give one high dose methotrexate. So we aim to give 4 high dose methotrexates in the course of that patient's treatment. Unfortunately, what we have found, though, is patients that present with CNS disease upfront who are HIV positive and who present with a low GCS, the mortality rate is almost 100%, I would say. We've not salvaged any of those patients. So when this patient presented, remember, he came in with bone marrow involvement and he had CNS disease. So we had to toy between whether we give our EPOC, which may not be the best for him. So that is why we chose the hyper-CVAD because of the marrow involvement. And unfortunately, I mean, he responded very well, and he had made it through the 4th cycle of hyper-CVAD, and on completion of it, he actually developed overwhelming sepsis, and he died from that. So it was a sad case, but that's just our experience with Burkitt in the HIV buckets. We do get the odd cases of the sporadic type, and we tend to use either the R-Codox MIVAC or hyper-CVAD, just depending on the patient's ECOG. Sometimes we get these young females who might be a bit, frail at the outset, so we tend not to want to be very aggressive, and we might choose the hyper-CVAD. So I wouldn't say that we have one fixed protocol for every patient, and it's patient specific. So with that, I don't think I want to say anything more. I'd rather open up for some questions. And I see Sharok says that Rasburicase is Section 21, extremely expensive, 35,000 70 kg patient. And he also mentioned, as Jasmine went through the case, that tumor lysis is cell destruction, whereas Warburg is a tumor metabolism problem. And interestingly, something popped up on for some reason, I don't know, our phones listen to us, but Warburg actually won the Nobel Prize for his discovery in 1931. So that's just a fun fact that I learned this weekend. And yeah, so I don't know, Maresce, if you want to say anything from your side.
No, not really, but thank you for helping assist me when I go and leave. I know I can always count on Albert Latuli to come to my rescue. And honestly, I came back. So he came in on a Thursday, Friday, and he was managed over the weekend. And I came on the Monday, and I was told beforehand, you're going to find a very sick patient. And when I walked in, this patient was sitting up chatting. I'm thinking, what is all the drama about? But yeah, they did an amazing job looking after this
they did.
patient. So yeah, I just picked up, and yeah, I helped. We also presented this case at our internal medicine grand round as well.
Yeah. Yes, so I also thought this was really important because most of us expect to see tumor lysis with Burkitt's, and I must say, in all my years of treating Burkitt's, I've never seen a patient with Warburg, and for me, it was a learning experience as well. So I hope that the audience and the trainees, and I guess the more experienced clinical hematologists probably see it more often, but it's just an important message that one needs to suspect it, because here, the patient made it, so important. And I don't know if there's anybody else that wants to ask any questions or wants to comment. Cecile, if you you say that our epoch is very difficult to give. Can you tell me what is your experience then with these difficult patients? What do you use?
Well, obviously, it's the team who's on now. I'm the retired one. But what we have found is, for us, hyper-CVAD was more toxic than Codox-IVAC. I don't doubt that Codox-IVAC can be very toxic, but we have found better outcomes with Codox-IVAC for our high-risk patients. But what we use for our low-risk patients and our sort of low tumor burden type of early stage patients is the Carmen protocol from Italy. It was Professor Nowicki actually got it many years ago, and he then called it the modified Milan protocol because that's where it was first used. But you will see that it has been published now by the Italian centers as the Carmen protocol, which is a quite intense protocol that runs consecutively over about 2 months. The patient stays in hospital, gets all their treatment, and then they're done. And we have found that very good for our low risk disease and early stage disease. What I also absolutely agree is that CNS disease in Burkitt's is 100% mortality. Yeah.
Yeah, and the other thing, Cecile, like we've never transplanted any of our Burkitt's patients, even though some of them went into remission and all of that. I just want to know, have you all done any at UCT?
Well,
Any allos or
I mean, they
autos?
can correct me now, but what we've done, what I can remember, is 2 autos for patients who had Burkitt's leukemia who actually completed their treatments, 2 or 3 autos, because we felt that they just needed something additional. So we gave autos for some of the Burkitt's leukemias that came through everything. But those are the ones I speak under correction, 2 to 3 autos over the years, probably.
And then if anybody else on the call, I mean, we had one young sporadic Burkitt patient who came in with CNS disease. And, initially we had presented him to the oncologist, once we have treated him, whether he would benefit from sort of consolidation radiotherapy, and they advised us against it. And I see, interestingly, it is actually, we found out later that, it's not helpful. I just want to know if anybody else has ever seen any benefit. We've certainly not given any of our patients radiotherapy, but has anyone seen any benefit with these patients with CNS disease?
We have not used it, and we have had some CNS disease patients that we palliated just with high-dose CHOP methotrexate, and we bought them some time, but in all cases, we just bought them time. And high-dose CHOP methotrexate is a easier regimen. It's largely outpatient, except the admissions for the methotrexate. So that's a way that you can maybe buy time for a good performance status as CNS Burkitt patient, but it buys time. It cannot cure.
Okay, thank you so much, Cecile, for your contribution. I don't see any more questions, and so with that, I'd like to thank everybody for joining us for our session this afternoon, and we'd appreciate to take some time to complete the Google response form. It's on in the chat box here. And I wish everybody a good evening, and thank you again for your time. And we will see you next week. Goodbye.